Mr. Kilic.
Thank you. First of all, I want to thank you very much for the organizing committee, especially Dr. Patakos and Spargias for their kind invitation. And I'm very happy to be again with my friends here. Can you upload my presentation? Okay. I also want to thank you, Dr. Spargias, to give me this complex and headache topic. Really, because it's a challenging topic, a degree of uncertainty, a relative paucity of data, and it's not very easy to summarize in 8 minutes. There are a lot of options, as you know, for the concomitant coronary artery disease and severe aortic stenosis. We can do only TAVI to these patients, PCI plus TAVI, but in whom? In high-risk or low-risk patients. What is the optimal timing before, after concomitant? Can we do only isolated aortic valve replacement or bypass plus aortic valve replacement? When we look at the studies, incidence of coronary artery disease ranges from 20.8% to 81.8% because it's related with its definition. These studies define coronary artery disease as the mere presence of coronary artery disease rather than by the need of coronary revascularization. Thus, the presence and extent of ischemic coronary artery disease is often one factor that influences the decision for surgery or PCI among these patients. What do guidelines say? Great uncertainty favors bypass plus surgical aortic valve replacement in high-risk coronary anatomies, but there is no clear definition of severe coronary artery disease and no clear definition about high-risk coronary anatomy. Only European Society of Guidelines focus on the term multivessel disease. And when we look at the European Society of Guidelines recommendations, significant multivessel coronary artery disease requiring surgical revascularization favors surgical aortic valve replacement. It is same in the ACCR recommendation, severe coronary artery disease requiring bypass grafting. Right, and this is an update, and there will be much more update as Dr. Tutuzas underlined that there will be an update for the guidelines. It must be. When we look at these recommendations, there is only one recommendation about multivessel coronary artery disease with a syntax score, but we can also discuss the syntax score is accurate or not for defining the high risk of the coronary artery disease. So this is a classical knowledge, textbook knowledge that aortic stenosis symptoms are demarcation in course of disease. What are these symptoms? Angina, syncope, and heart failure. If angina, for example, survival will be 5 years, syncope, survival will be 3 years, and heart failure, survival will be 1 year. So in symptomatic aortic stenosis, we should change the valve as quickly as possible, either surgical or transcatheter. But the term angina here is very, very important. It is stable angina or unstable angina. If, for example, we accept the term unstable angina in patients with aortic stenosis, this means acute coronary syndrome, then we should, if that patient had a coronary artery disease, we should make PCI first in this patient. So we must discuss this point. So when we look at the patients with aortic stenosis and acute coronary syndrome, while it is clear that aortic stenosis patients presenting with acute coronary syndrome should undergo revascularization of the culprit vessel, but how many patients with severe aortic stenosis admit to an emergency services, STMI or non-STMI? Very low and high mortality rate. And patients with aortic stenosis can also have a rest angina unrelated with the presence or absence of coronary artery disease. Thus, main questions remain regarding the management of significant stable coronary artery disease in patients undergoing TAVI. So, revascularization in patients with aortic stenosis and stable coronary artery disease, also headache. Current guidelines aren't particularly clear on how these patients should be treated, but generally recommended 2 separate procedures. with concomitant procedures only recommended for those with very high degrees of coronary artery stenosis. For those complex coronary artery disease, both surgical aortic valve replacement and bypass are usually recommended at the same time. But for PCI and TAVI, there is no direct recommendation, but the general consensus in the guidelines seems to favor performing the two procedures as separate interventions. So rather than guidelines, it seems better to focus new trials. So it is also very important for the evaluation of coronary artery disease in patients with aortic stenosis. This is an example from the TAVI trial. Angiography-guided PCI and physiologically guided PCI will be compared, but coronary hemodynamics reflects combined effect of coronary artery disease and the severity of aortic stenosis, but interpretation of FFR can be challenging, especially in aortic stenosis. So can we use only TAVI strategy? This is a very, very important study, activation study, revascularization versus conservative treatment, show that there is no difference between two groups, PCI group and no PCI group, and even in the PCI group, bleeding was high. So Notion 3 trial is very, very important. New trial, compared to PCI versus conservative management in coronary artery disease with FFR below 0.8, and that MI urgent revascularization was low in the PCI group. So maybe PCI was strongly recommended to be performed before TAVI in this patient, but could also be performed during or within 2 days after the procedure. But the most important study, we are waiting the result of this study, the complete TAVI study. In this complete TAVI study, patients with severe symptomatic aortic stenosis and coronary artery disease, first, successful TAVI with a balloon expandable valve will be performed, and one-to-one randomization will be occur, FFR-guided PCI or medical therapy. So this study will show the exact results to understand the importance of PCI among aortic stenosis. If we use PCI plus TAVI strategy, what is the optimal timing? This is the results of the revascularization TAVI registry and show that it is very, very important. All of the complications are high in PCI concomitant with TAVI. So if we use PCI, it is better to do either before TAVI, but most important, the results are better in PCI after TAVI. This is a very recent publication published in the Euro intervention, and the high risk criteria for, the complex PCI terms were determined here, like the coronary lesions, left main, three-vessel disease, and bifurcation PCI, and calcific lesions, and showed that 1 year outcomes were better if the stage procedure were used. So if we will do PCI plus TAVI, it must be staged. So one of the other main questions, surgical versus transcatheter strategy, very important studies, and also I don't want to underline that the meta-analysis, because in the meta-analysis you can select the sometimes the bias criteria with, if you select more surgical, for example, publication, the results will be good, but these are the propensity matching studies. One study showed that in patients with severe aortic stenosis and complex coronary artery disease, TAVI plus PCI and surgery plus bypass were associated with similar rates of MACE after a median follow-up period of 3 years. But TAVI PCI exhibited a higher risk for repeat coronary revascularization, so it's an expected for the PCI. A recent study from Spain, also despite a lower baseline risk, bypass plus surgical aortic replacement in patients with aortic stenosis and coronary artery disease was associated with a higher rate of death and stroke compared with PCI plus TAVI, highlighting the necessity for large randomized analysis. This is a very important study, TVV Vessels trial. The study stopped due to higher mortality among surgery plus bypass group. But another study showed that surgery plus bypass is better than TAVI PCI. So larger randomized studies are required to optimize the better outcomes. So how to interpret the available evidence? It's a good algorithm. If a patient, for example, acute coronary syndrome, PCI before TAVI can be acceptable. If a patient had a chronic coronary syndrome and no angina, no PCI, except if left main or right coronary artery ostial lesions. If a patient had a chronic coronary syndrome, angina, and PCR before TAVI, if PCI appears simple, and PCI after TAVI if angina persists. And decision between surgery and PCI related with patient vulnerability, presence of diabetes or not, and distribution and complexity of coronary artery disease and coronary access after TAVI. And the heart team evaluation is very, very important to make a good decision. Thank you very much for your attention.
Thank you very much, Professor Kilic. This is the questions are arise, and probably this is a personalized decision. For example, you don't know if a patient with severe aortic stenosis, how it reacts in complication during a PCI, or you don't know if a patient with severe coronary artery disease, how it reacts in a rapid pacing during the TAVI. So the timing is important. So personalizing is, I think, is the key to this question.
Congratulations for the presentation. It's excellent, and thanks all the people who participated and presented. I think that we need to realize that every patient is different. Everyone needs a little bit different based on guidelines, and we need to have a heart team discussing every time what is the best for each patient. Based on the guidelines, we can extract conclusions and go from then on. Yes. Thank you very much.
Thank you.
Okay, if there is no other question, we can proceed to the...
One more question. If we had the stem disease,
left main.
What do you propose for the patient with serious stem disease?
Left main disease.
Left main. It is related with the always status of the left main. For example, in patients with aortic stenosis with angina, all the procedures and trials show that TAVI first. And then stage procedure, left main PCI can be done. But if it's very calcific proximal left main disease, maybe this can be discussed by the heart team, and this patient can go to surgical aortic valve replacement plus Lima LAD.
TAVI with protection. You can put a stent in the left main just to be there in case of obstruction. If there is ostial left main disease, you need to protect the left main by putting a stent there.
Of course. Yes. These are the mechanisms. And selection of the valves, very important. Balloon expandable valve. I don't want to summarize all these in 8 minutes. For example, commissural alignment is very, very important for future coronary access. So much topics.
We need 2 days to discuss this. Yes, coronary artery disease in young people who need a valve. And okay, thank you very much, Professor. Dr.